Welcome to the September NASMHPD Meet Me Call. This month's Meet Me Call will be a two-part session. First, we are honored to welcome Dr. Belina Shaw and Dr. John Palmieri. They are both senior medical advisors at SAMHSA. They will provide an overview of the draft National Crisis Guidelines 2.0, and that will be followed by an opportunity for dialogue with Dr. Shaw and Dr. Palmieri. For the second part of the call, we are pleased to have Tiffany Wu, Senior Enforcement Advisor from the Employee Benefit Security Administration with the U.S. Department of Labor. She will discuss the enforcement of the Mental Health Parity and Addiction Equity Act. Thank you for joining us today. We greatly appreciate the partnerships. I want to remind the audience that please put comments and questions in the chat. Dr. Shaw, please go ahead.
Hello, thank you so much. And I'm going to hand it over to John. I can share my slides, John, if you'd like.
Sure. Yeah. Hi, everyone. I'm going to get started, and Belina and I are probably going to do a little bit of kind of bouncing off each other as we kind of walk through these slides. To talk a little bit about the work that we're doing with respect to the crisis service definitions and standards and the updated national guidelines. I think many of you are tracking some of this work, but we thought it was a good opportunity to provide an update and also to get some feedback and questions from you as well on this process. So you can go to the next slide, Belina. I think I'm going to skip over this quickly. Obviously, I don't think that's the right deck anyway.
Yeah, I think I switched. There's two that look exactly the same, and I think I shared the long one and not the short one. Let me bring up the short one. Just try to. Sorry about that. Yeah,
no, it's all good.
All of that. Today is the 19th. All right.
How many physicians does it take to run a PowerPoint slide deck? I think that's the question for the day.
We had Brian in it, make three. All right.
Okay, so we are, as many of you know, kind of ambitiously undertaking a few different deliverables this calendar year, including crisis service, refinement of crisis service definitions and standards, building off work that NASMHPD has done with McKinsey and other partners in helping to try to align our understanding of what these crisis services are, different levels of care, staffing requirements, et cetera. We'll talk a little bit more about that. We are using the definitions and standards as kind of a foundation on which we are building an update of the national guidelines, the crisis guidelines, which, as you know, for the adult version or the broader version came out in 2020, and then there was a youth-focused version that came out in 2022. But we are using or leveraging implementation of 988 and all the tremendous accelerated growth that's happened in the crisis space to take advantage of this opportunity to update the national guidelines, which hopefully will include and reflect both adult and youth voice and perspective in the updated guidelines. We are also well underway with a third document, which is a companion toolkit that is focused on mobile crisis services, which is really more of a kind of a ground level or not far above ground level kind of implementation support related to mobile crisis. And then there is a fourth document that we're not going to talk about, but that because CMS is primarily the driver of this document, but we are collaborating very closely with them on that, which is financing crisis services through Medicaid and CHIP. So that's a guidance document that will come out in 2025. Along with the creation of a technical assistance center or structure within CMS that will support financing of crisis services through Medicaid and CHIP. And so we're working collaboratively with them on that. You can go to the next slide, Belina. So as I said, this is accelerated and pretty aggressive in terms of a time frame. We have done a tremendous amount of work already through our Training and Technical Assistance Center and with the expertise of a sprint work group and our own advisory council to provide input through a series of convenings, both virtual convenings and then a couple of in-person convenings that happened in July and August. to gain feedback and help us revise kind of the framework, the outline, the language around the crisis service standards and the national guidelines. We are now in the process of continuing to refine those draft documents. We are very interested in sharing our thinking about these draft documents with a broader audiences. So part of the reason why we're here is because we very much value the partnership with states and territories and tribes, and want to make sure that what we're developing is reflective of your needs and your concerns. And so there are some informal listening sessions that are happening over the next couple of months. And then we are also planning to publish these or post them for public comment sometime later in the fall. We will have a broader distribution to get additional feedback on both the service definitions and standards and the guidelines, with the end deliverable being documents that will be disseminated to the public, ideally or hopefully at the end of calendar year 24. Next slide, please. And Blaine, just tell me whenever you want me to stop and you want me to hand this over to you. Okay, so with respect to the crisis service definitions and standards and how that fits into the guidelines, as I mentioned, there has been a need to try to obtain more clarity and more alignment around what we're talking about when we're discussing crisis services and different crisis services. We know that because there's been just such tremendous growth and rapid growth in crisis systems across states, across territories, counties, and tribes, that there is in many respects, a high level of variability in terms of how these services are designed, supported, staffed, et cetera. And so we wanted to try to help inform that conversation as best we can from a federal perspective to align on what we're talking about when we're talking about these different services. This is particularly an issue. It's less of an issue with respect to 988, but more of an issue in mobile crisis, and then also even more so with crisis stabilization services, which have a high degree of variability from state to state. And so one of the reasons that we think this is important, or a few of the reasons that we think this is important, are we want to try to have the help seeker have more clarity around what these services are and what they're not. And so when they're in need of services, like having more clarity and alignment, not that it's going to look identical, obviously, across the board, because there's not any way that we can, certainly it's not our role to do that, but we want to make sure that where there is opportunity for alignment, that we can do that so that there's more clarity and transparency for the help seeker around what they can expect. We also want to try to provide some tools and some guidance for system leaders to be able to understand how these different service components vary and how they could potentially be pieced together in a way that works in an individual community. And then importantly, we want to try to provide more alignment for payers because we know from many sources of feedback that payers have identified the variability in these definitions and standards as a barrier for coverage for development of plans that can pay and sustain these services, again, particularly on the stabilization side. You can go to the next slide, Blaine. So in our work, we have tried to maintain kind of an overall sort of framework or approach for how we're addressing some of the challenges that exist in this space. And so you can see here some of the ways that we've approached this work. With our work group, with our advisory council, and obviously with the broader public as well. We are trying to find a middle path between recognizing where we are currently, recognizing that there's a lot of variability in the development of systems and the accessibility of services with kind of a vision for where we want to go. So we don't want to dismiss all the great work that's happening, and we also want to push the field as much as we can toward that broader vision and access for care. We definitely don't want to, as I said, dismantle work that's happening, great work that's happening at the local level. So we want to make sure that we're building on that, and then where we can sort of provide more clarity and help kind of shift alignment, we want to be able to do that. We know that while we're outlining standards and principles around the guidelines, these are kind of intended to be sort of a national kind of North Star, really, that we're trying to create around these services. But we know that not everybody's going to be in the same place in terms of their implementation or the development, or it might look a little bit different from community to community. So we are really just trying to align to that vision and to that North Star, and just sort of help clarify what the pieces are and how they could potentially be assembled together. And then we also recognize that while we have and will continue to engage a lot of diverse voices in this conversation, the guidelines are kind of our best effort to align with what our vision is for crisis care and for help seekers, understanding that getting full consensus from a group of experts is always going to be impossible. But we do feel like as much as we can continue to move the work forward, that is an important success and an important milestone. Next slide.
I'll pick up from here. Of
Thanks,
course,
Polina.
computer
Oh,
decides-
sure, you got the picture. Great.
Oh yeah, so that's the thing. Yeah, the quick slide. But as we said, it's a sprint and a collaborative. And so we're thankful for a group of partners, and part of this is that we just continue to do this work and get you guys and more voices at the table in different forums. And so so there's the goals of our standards and definitions are really refining the proposed definitions within the 3 pillars that I'm sure you're aware of: someone to contact, someone to respond, and a safe place for help. And that in these 3 pillars, we are really focused on categorizing services within and defining levels of care, especially we know in this safe place for help space, so that there have been many different versions and iterations of what crisis stabilization looks like. We will really, especially in that area, wanted to clarify that, and that's been really the bulk of our time focused on clarifying that space. And so here is a laundry list of what the last iteration. This is changing rapidly every day. As of Monday, it's somewhat modified, but just a snapshot to see the categories and how at least we're trying to level, although we'll probably continue to modify the names based on feedback from our most recent work group. And so moving on to also to the national guidelines. That we are the foundational that foundational circle at the bottom is truly meant to be at the bottom, because it does define what each of these services look like, and the guidelines are then focused on how to make those guidelines, how to make those services. We create a system. And in the guidelines, there's some evidence and data review for what we know, knowing that there's a lot of what we don't know in this space as well. And that's why we've leaned so heavily on experts to support this. And refining, and really we're refining 2 main areas in this, some overarching now principles for the crisis continuum, and then also a framework for what we've defined or described as a coordinated crisis system of care. That is a tongue twister. And so really providing a framework for that, and especially in that coordinated crisis system of care, we really would love to have some of your feedback as well. And so John has really mentioned that approach. I will not really get into the details thereof. But the overarching now principles to guide the long-term development, here's the principles, and just we love as we get into this, we'll just any feedback broadly about them, I'll give you a quick overview of them. This work is developed in a systems-based approach, that this is not just a bunch of services in a community. That it's person-centered and family-focused in providing the right level of care at the right time. That means that there has to be enough services to provide choice to provide that right level of care at the right time. It's safe not only for the person that is receiving services, that we are mitigating risks of suicide, overdose, risk to others, but also safe for the person that's receiving services, but also, and probably most importantly, it's safe for the person that is seeking services, that they feel safe and in the care that they're receiving. And that really leans into being both recovery and resilience oriented, which is another bullet there below. We really are focusing on many E's here, effective of high quality services that are equitable and focused on evidence, either evidence-based or evidence-informed. And then also looking at being trauma informed throughout the whole service continuum, especially when we know that crisis care and high acuity care has the risk of being traumatizing for individuals, and we might be seeing people on their worst days in the crisis care continuum. Developmental appropriateness is paramount. There will not be a second document for youth, and then the needs of older adults as well as people with intellectual and developmental disabilities will be focused, as well as those who have complex or additional needs such as co-occurring medical conditions. More pictures, that's the summit there, and this is really where we want to lean in and get your feedback. We have these coordinated crisis system of care elements. These are the core elements. They've been tweaked a little bit, modified a little bit since we met all day on Monday, and we're still awaiting a new draft from the contractor to support our discussion and decisions. But these really are still the core tenets of what is in a coordinated crisis system of care, not just someone to call, someone to come to you, a safe place to go, or the place to go, the old language there, not just 3 services, but how do you make those services into a system? So we know we've really identified these as some of the hallmarks of how to make this a system. Knowing that administration, structure, and oversight are key, and this is why we are coming to you, is that we know that a system has to have some degree of accountability, responsibility, and albeit shared with the community with some governance and support, that there has to be someone who has an ultimate responsibility for making this a system. And we know that policy and financing really are key to making sure that system is sustainable. How do we communicate about this system? How do we make sure that the public is aware, and also the public is engaged from the inception of the services to the evaluation of the services and that service delivery in between? We once again are highlighting equity in this space, and then knowing that evaluation and data are key, so that first of all we can get that evidence that we know that we are lacking. Right? We can really learn collectively from the data of the systems that are being built, but also knowing that for that individual user experience, that we know that people are getting care that is meaningful, impactful, and then also making sure that we are getting those process outcomes and metrics that are going to be important for system development as well. Technology is a key tool that we know we'll have to use, and we'll have some talk about that, as well as workforce, which we know is the rate limiting step to basically doing all of this. So we have draft documents, we've gotten feedback, we've gotten virtual and in-person convenings, and we have a draft that's pending. And so now we just want to reach out to you guys. We really want to reach out to our national leaders and understand what's missing, and then what spotlight practices should be lifted up. That is the exemplars to share. I think that's cue the NASMHPD team to share a link as well. And how should we frame the scope, especially of this coordinated crisis systems of care? I'm repeating the slide just so that you can have it fresh as we join this discussion. But we do recognize that we want to be visionary and concrete in these guidelines, but also not overly prescriptive, and want to strike that balance. And so would love to have your feedback as well about how we can best really document that in a way that is helpful, but not necessary, and maybe even help you push the envelope, but not in a way that feels like you have to separate yourself from where we're going. So yes, so these are our main elements, and we are opening this up for discussion at this time. Looks like Sherry Dawson has her hand up. We can take your question or comment.
Can you hear me?
Yes, we can.
Okay, well, first of all, thank you. It's good to see both of you. And thank you for the opportunity to at least provide a framework and a structure. One comment I would have, or for consideration, is just having been on the state side not long ago, would love the documents to be even more user-friendly. Consider like less narrative, those examples that you just talked about, you're trying to get more bulleted, kind of highlight key points, state examples that somebody could go in and, you know, kind of tweak and take away. As well as the voice of the individuals with lived experience and you know, how, again, they like to receive services that you all mentioned, infographics, those kinds of things. And then the second consideration is just in thinking about where every state is at such a different place in their service development, especially as it relates to service definitions, and even the mention of the ASAM and LOCUS. To continue to consider a larger menu of tools, or for states to consider. I can say from our state, whenever we changed a standard of care, a service definition, a standardized tool, or added a new screening, you know, there's regulations, sometimes public hearings, managed care contracts, EHRs, you know, data collection. So just thinking about the opportunity to really help states go through their process, but being patient with perhaps the menu of opportunities that they have, as opposed to focus on just a couple.
Yeah, thank you for those comments, Sherry. I mean, I think we definitely are struggling a little bit with, to your first point about wanting to have a document that's comprehensive, but then perhaps like has versions that would be more digestible, because we are aware that, you know, putting 100-page document in front of, you know, an audience with a lot of text and not a lot of graphics can be challenging. And so we want to make sure that we're sort of developing materials that are going to be used and usable, you know, by different audiences. And so that is something that we're thinking through. And then we are very much aligned, I think, in terms of trying to create a menu of sorts of different services and different levels of care, knowing that not every state is going to have every single one of these services right away, or may not have it, may not be on their planning agenda for the moment. But we want to make sure that we're sort of kind of outlining what we mean by these services. And this is kind of the menu. This is what's on the menu. You know, states are going to have to figure out what on the menu they're going to take, how they're going to fit those things together. What the regulatory environment that is going to allow that, et cetera. But we're just trying to sort of create options that are aligned with our overall vision.
Thanks. And I'll add as well that as far as some of those granular details, I think a model that we'll start to follow is creating implementation guidance in these toolkits. The last document, the last 2020 guidelines, did use the word toolkit in its title, but it really didn't follow the true it didn't have great fidelity to the way that SAMHSA historically has created toolkits. If you look at, say, the ACT evidence-based practice toolkit or something like that, that has multiple granular chapters. And so we're in the midst of a very comprehensive document that it will likely trail a little bit the two guidelines, the mobile right crisis toolkit, just to be able to provide those additional details, lots of examples, links, people who are already doing this in the field, and make it super practical. So we are definitely looking at those two pieces. It's a little bit hard to create the document when you have a moving target of standards at the same time, though, but we're trying to do it all.
Thank you both.
Thank you. Carrie?
Yes, first off, I would say I really applaud you taking on this project, because it's a huge project, but it is so needed. And one of the things that I think is the biggest challenge across our nation right now are the varying terms that are used from state to state to state about different levels of care, whether it be stabilization in a less than 24-hour type of facility, a 3 to 5 day type of facility. And there's terms that are used in such varying ways across the nation that it can be really challenging to have a discussion from state or across states around our crisis system. So I really applaud the work that you're doing to try to come up with a a guideline, a set of definitions, if you will. And you're right in that you're not ever going to have full agreement on that. But by virtue of just having one, I think will make the dialogue so much easier and so much more robust as we continue to move forward. So I really applaud the work that you're doing. I do like the idea of more examples, like real life examples to be put in so that folks can get not just a definition, but a tangible to look at. And I think that's, you know, work that will continue. But the one thing I would say that would maybe be a little bit of a negative is that I feel like there has been this tremendous amount of work that has been done and been achieved over the last 10 years in terms of building the crisis continuum in our nation. And I feel like the document kind of starts out really pointing out all the problems and the barriers and the negatives without really a paragraph to acknowledge the change in the number of mobile crisis teams across our nation, the change in crisis receiving facilities across our nation, because it is really unprecedented, the amount of growth that has happened. And so I feel like there needs to be a paragraph that really acknowledges and celebrates that before we get in a little bit more to the work that continues to need to be done. But I certainly applaud the work that's been done. I think this is so needed. And I was a little bit afraid that we weren't going to get more into the definition types of things. And so I was so thrilled to see that we truly are, which will help move us all forward. So thank you so much for that.
Thank you. And thank you for the feedback on sort of the positive framing. I think that's really important. And so I appreciate that.
Thanks. Lisa?
Thank you both so much for the presentation and for getting this important discussion started. I have a few comments related to the private sector, and there were several mentions in the draft guidelines about engaging the private sector and private payers and making sure that there's no wrong door for individuals, including those that are privately covered with insurance. So my questions relate to how do we engage the private payers and when do we start, which I think is probably important at this point, because there are a lot of issues on that side in terms of who's in network, who's not, how those differences are approached, what happens to somebody who referred between crisis services and more traditional treatments, and creating more of a continuum of care under the private networks, which sometimes doesn't really exist like it does in the state system. And I think that's really important in terms of the sustainability that we have that part of it set up. There were a lot of mentions in the draft about the commercial payers, but I think we need a lot more detail in terms of how to create referral pathways between public sector and private, how we provide any kind of oversight if there's a state administration that oversees insurance that maybe could be involved in setting that up. Can we make sure that these services are an essential benefit? So lots of questions around how we set that up. And I think we need a lot more detail and maybe some protocols in place in terms of making sure that happens.
Thank you. That actually is a really great place for us to discuss maybe some of like this policy, like that was your state insurance commissioner and things like that. I think those are definitely some areas to lean into on the administration and policy areas of this coordinated crisis systems of care. So yeah, I definitely think that we could talk a little bit more about that. Just as far as private payers that have been engaged, we've had about 3 or 4 plus some national professional organizations that represent them as well that have been engaged, actually opening up and speaking at the standards and definitions meeting. So they have been at the table, not only at this convening, but through work that has done even prior to me coming to SAMHSA, through NASHPD and McKinsey, and really starting to open up that dialogue. And really one of the key steps that they identified as needing to really needing to be in place for them to more broadly cover is a set of clear standards and definitions because you know, they especially need to know what they're covering as their that's the main way that they will be able to understand and set rates and identify how they will include those in their plans. So we have been engaging them throughout this process, and thank you for your feedback. We can definitely include that a little bit more in some of those, especially policy and I think administrative structures and financing, obviously, areas too. Tanya?
I just put a note in the chat, just agreeing with that, and then also asking about Medicare. I know I've brought this up. I think we're feeling like we have no idea how to leverage Medicare for crisis services. So I don't know if that's in the document and or there's TA plan, but just wanted to flag on the sustainability side. That would be really helpful.
Medicare, there are some advocates that are strongly engaging Congress and for some pilots and doing some work in that space, and we are engaging with them. You know, Medicare at the end of the day, the way that they pay is through you know, having that clear guidance, especially through Congress. But so it is an area that needs to grow as well, to really get all of the legs of the stool of payment out there. But we are working on a couple of documents that will touch on some of the, I'm thinking of a document that NASHPD and Vibrant are working on that might be able to touch on that a little bit as well. But we are working, there are some folks that are working on a path forward for.
Okay. I thought some Medicare regs went out this year, so I was also referring to that too.
Yes, I think that also depends on, and actually it depends on the level of care that you're discussing. So especially those emergency psychotherapy codes will be especially helpful in the standards around, say, urgent care. That those could be especially helpful. I think that some folks are really finding some area for growth in the space around that high acuity, high fidelity to the original Crisis Now model for facility-based crisis stabilization. But yes, for the urgent care, there is definitely some space there, especially with the codes that have come out, and we can continue to think about how we include that in our future guidance. Thank you for that point. Robert? Robert? Robert Connor?
Yes.
Yes, sir.
Can you hear me?
We can. You're a little faint though. Robert, you are a little faint. We can, can you get closer to a microphone, or?
I'll try. Is that better?
Minimally, but let's try.
I wanted to ask, does building a type of database like this, whether you're considering AI issues?
We're
Yeah.
unable to hear.
No.
Robert, if you could submit your question in chat, that would be very helpful, please. And then Wendy Morris was next. Melina, if you want to.
Thanks, Amy. Yep, Wendy would be great next.
Great,
All right,
thank you. Well, I just wanted to speak for just a minute to evaluation and data. Again, you already made the point how important that is. You know, what funders want to know may or may not be different than the folks running the system need or want to know. Definitely, you know, you want indicators on patient outcomes. I don't know if there's an acuity system kind of built into that, because not all calls are the same. So when you're really looking at outcomes, some of those high acuity calls those outcomes are probably going to be of much more interest to folks. And then workforce metrics, you've got workforce on here, recruitment, retention, but is there, you know, are you able to collect data or evaluate in a way that makes correlations between what's happening with your workforce and the acuity of your calls, the types of situations that they're being asked to deal with? So those were just a few points. Thanks.
Wendy, I have a question for you. When you say workforce metrics, are you talking about like qualitative metrics around workforce wellness?
Yeah, it could be that. It could also be, you know, turnover, burnout, some things that you might be able to measure more objectively. But I do think the subjective measures are also important because we know when you're taking high acuity calls, especially when there are not good outcomes, it can be very difficult, and we're not always good about taking care of, you know, our workforce in the healthcare system generally, not just behavioral health care.
Thank you, Wendy. Considering AI and the database development, I do know that there's some mention of AI in our technology section. John, do you want to speak a little bit to that?
Yeah, I mean, I think that the references that we have to AI have been mostly in the context of 988, and really from the perspective of quality improvement efforts in the 988 system. So not using AI as a responder to 988 contacts, but leveraging AI to support training and capacity building and skill building for crisis workers related to AI support of analysis of interactions and language and tone, et cetera. So there has been some discussion of AI in that setting. And I mean, I think obviously there's a lot of interest in AI generally across the board, although of course a lot of potential risks as well. So in fact, the White House and the federal government has put out some recent guidance around the use of AI. So I think there are opportunities there, and also obviously things that we need to be mindful of with respect to risks.
Yeah, and I know there's some opportunities around, especially in the follow-up space with risk stratification and natural language processing. And I do know of some companies that have been doing that, but that always has an overlay of a human that is processing that data, and really it's a tool to lean back into support of a staff member, as opposed to at this point, I think having AI be the responder or the supporter per se. From Illinois, we have a concern that 988 may be expected to be a pre-authorization service for crisis care. However, many individuals may prefer contacting their established providers, and an over-reliance on 988 could overwhelm the system. I think, John, I'll let you take that one, and then maybe you could talk a little bit about geo-routing, because I feel like that's an exciting update that probably it's a great time and place to share that too.
Yeah, I mean, I'd be interested in understanding a little bit more about the comment here in terms of a pre-authorization. So, you know, people contacting 988 don't have to provide any insurance information to receive the service. I do, and maybe part of this is connected to a lot of the existing crisis lines, you know, that might exist at the state or county or local level that could potentially be migrated over to 988. And yes, I mean, I think capacity is a legitimate concern there, because there is the potential that if there were more consolidation of crisis lines to 988, we obviously would need to be very mindful of the capacity building and the importance of that with respect to answering calls, chats, and texts. And it does connect, you know, to the geo routing issue that Belina just mentioned. I think all of you are probably tracking the recent activation of geo-routing for calls for 2 of the major carriers, which obviously connects people closer to their nearest 988 center, which is a huge milestone. It's been years in the works, actually, even prior to 988 implementation. So really, really excited that actually happened just this week.
Thank you. So I know we have until 12:40, so I feel like if we yield a minute, no one will be upset with us.
Well, thank you, Belina. Thank you, John. That was very good. If people think about the issue and they have other comments, what's the best way for them to get in touch with you? Is it okay if we have the comments come through us and then we'll pull them together and pass them on to you? Is that okay?
That's perfect, Brian.
Yeah, of course.
Yeah, and I think that exemplars, the list of exemplars or just information. We just want to make sure that we are broadly identifying the strong work that goes on around the country. I know that some states' programs have a lot more press and publicity around the work that we're doing, but we know that a lot of programs, larger and small, states large and small, different geographies, et cetera, are doing great work and want to be able to highlight that in this document, documents to come, and also in some of the convenings and things that we have. So thanks for that. We're looking back for feedback with such exemplars by, I think we said next Tuesday. So get what you can in, and we can always, there's information for us to contact you for additional information if we need that.
Well, thank you. And this is important work. So well done. And anything we can do to be helpful, please let us know. We really value the collaboration. So thank you.
Thank you all.
Thanks for having us.
And now we'd like to move on to Tiffany Wu from the Department of Labor to discuss parity enforcement. Thank you, Tiffany, for being here. Please go ahead.
Hi, everyone. Hope you can hear me okay. I'm Tiffany from the Department of Labor Employee Benefits Security Administration. Just a real quick background about me. I've been with EBSA for about 15 years now. My background is in law as well as mental health treatment delivery. I actually lead a team for the last several years. I've been leading a team within EBSA that focuses on oversight and technical support for mental health parity enforcement. And we'll get into some of the details on that. I'm going to start off at the top by letting everyone know that I'm not here to talk today about the new MAPIA regulations that were just finalized last Monday, just a little over a week and a half ago. But I will be talking about some of the enforcement activities that my team is focused on and some of our enforcement priorities currently as well as in the coming year. The next slide. I'm going to take a few minutes at the top to talk a little bit about my agency and how we fit into the puzzle of mental health parity enforcement. Slide. Yep. So just off the top, my agency, this is our mission, and some of the pieces I want to highlight for you are the pieces about welfare and health benefits, as well as vigorously enforcing the law. So my particular office is the Office of Enforcement, and so we conduct investigations, civil investigations related to health benefits, among many other types of benefits. The agency also does investigations that look into pension benefits, but we're here to talk about health today. Next slide. My agency's jurisdiction is defined by ERISA, the Employee Retirement Income Security Act of 1974, and the types of, the types of plans that my agency has jurisdiction over are ERISA-covered plans. ERISA-covered plans are generally employee benefit plans that are sponsored by private employers or employee organizations like unions. So the type of benefit plans that I'm talking about that my agency oversees are not things like Medicare or Medicaid, which would be public plans, but there would be private plans. Many Americans, I think the latest count is somewhere in the neighborhood of 150 million workers get these types of benefits through their jobs or through their former jobs if they're retirees or their dependents, and they get these types of health benefits through their parents or guardians. So this slide here details the many different federal laws that my agency is responsible for enforcing. And that includes MAPIA, or the Mental Health Parity and Addiction Equity Act of 2008. And next slide. So how we actually do this enforcement is my agency is divided up into 10 regional offices as well as a national office. I come from our national office, but each part of the country has a regional office that's staffed with investigators that conduct civil and criminal investigations, looking into compliance with the laws that were listed on the prior slide. We also, something that's little known, but I'm trying to publicize more, is each of our regional offices is staffed with what we call benefits advisors. And benefits advisors are folks who are trained in the legal issues and the practicalities of employee benefit plans, and they take calls from the public, members of the public, participants in plans, from plan administrators, and folks in the benefits industry who have questions Oftentimes we get questions from folks who are trying to access mental health benefits, and these benefits advisors, our benefits advisors, are trained to help them navigate that system. They do a lot of conference calls, getting folks on the line, making sure that folks are getting the benefits that they are entitled to. Next slide. So in terms of Department of Labor's EBSA enforcement, and we have a lot of different laws that we enforce, but one of our huge priorities, and has been for the last few years and will continue to be coming into the next year, in the coming years, is MAPIA, or Mental Health Parity Enforcement. It's part of it's one of our national projects. It's a huge priority. So what exactly that means is that we have a lot of our resources. I think the latest count is nearly a quarter of our enforcement budget is devoted to mental health parity enforcement. Next slide. We're going to talk about a little bit about what that means. So just in general, MAPIA, or the Mental Health Parity Addiction Equity Act, requires that group health plans and insurance companies have to provide mental health and substance use disorder benefits at parity. And so at the heart of what's going on here is there's a comparison between what's going on the mental health and substance use disorder side for what is being the types of limitations that are on those types of benefits, in comparison to the types of limitations that are being placed on what the law calls medical surgical, which is basically everything that's not considered mental health or substance use disorder. So the thing that we are comparing, that the MAPIA requires comparison of, would be the limitations. So we think about, when I think about, and I train folks on how do you think about mental health parity compliance, I think, well, what is the limitation that we're thinking about? Is it quantitative, like is it a visit limit or a day or treatment limit in that way? Or is it a financial requirement, like a copay or co-insurance where folks have to pay something? Or is it what we call a non-quantitative treatment limitation? In other words, a limit on treatment that's like not based in a number. A classic example of a non-quantitative treatment limitation would be like pre-authorization. Or some kind of hoop that you have to jump through that's not based in a number necessarily, but that really can limit care. And we all well know that processes like pre-authorization and other medical management techniques can absolutely be a vehicle for limiting care. So it's important to know that MAPIA doesn't prohibit those things, but just says that if you do those, if plans impose those kinds of limitations, that they have to impose them in compliance with the parity requirements. So next slide. So in 2021, actually it was passed in 2020, but took effect in 2021, plans and insurance companies had to, they were required to basically do their homework to show MAPIA compliance. They had to perform and document what their parity analysis was, showing, have you done your homework basically to show that you are in compliance. They had to make those comparative analyses available upon request when the OL and when members of the plan came asking. And then the law also required at that time, the law changed to require my department to review a certain number of those comparative analyses every year. I believe the number was 20, but we've reviewed far exceeding that number. I think the current count, it's not 20 per year. It's that first year we did an excess of 200. And then it's, yes, I think that the total count as of now, if you're just kind of counting cumulatively since 2021, it's upwards of, we've requested more than 400 comparative analyses for all different types of non-quantitative treatment limitations imposed by plans, and we are reviewing those currently. Next slide. The law also required that, the law in 2021 required an annual report that my agency would put out along with Health and Human Services as well as Treasury. Those are the two other federal agencies that share jurisdiction for MAPIA enforcement. And so together we put out an annual report to Congress. There are two reports that are currently already published, and the next one is coming soon. I understand it's in clearance now. Yeah, and you can go to these websites here to take a look at it. They describe in detail the types of non-quantitative treatment limitations that we're finding, as well as areas of correction and areas of concern, problems that we're seeing when we're looking at plans. And next slide. So if you were actually to look at those reports, some of the common issues that we're running into is that many of the plans and issuers were really unprepared and continue to be really unprepared to provide their compliance analyses when we request them, even though the law has required that since 2021. Yeah, and even though MHPD has been in place with parity requirements since 2008, many plans and issuers we were finding they weren't prepared. They hadn't done their homework. They provided something that didn't really answer the question of are you in parity, and was missing the required detail that the statute requires to be in those analyses. So my department has been engaged in a back and forth with them as required by statute. So we have identified for each comparative analysis that comes to us that is deficient, we say, okay, well, these are the parts that are deficient. You need to provide X, Y, and Z. And then we engage in a back and forth to get the information we need. But ultimately, I think MHPD compliance for non-quantitative treatment limitations can be quite complicated, which is why we are engaging in a process of back and forth with the plans. But all that being said, my department has found a lot of success in addressing certain types of NQTLs, for sure. For example, exclusions of key treatments for mental health conditions like ABA therapy or applied behavioral analysis therapy for autism spectrum disorder. We've seen in a lot of plans like blanket exclusions of that type of treatment, which is a core treatment, I understand, for autism spectrum disorder. And we don't see those types of exclusions for any core treatments on the medical surgical side. Like we would never see a plan that just would not cover, would not cover like insulin for diabetes or would not cover a cast for a broken arm. Like core treatments for those types of medical surgical conditions are definitely not excluded, but we see it on the mental health side. So those are types of exclusions that my agency has been successful in identifying and has actually, in my opinion, moved the needle in terms of getting those kinds of treatments covered. Another example of that would be like nutritional counseling or medical nutritional therapy for eating disorders. We've been seeing a lot of blanket exclusions of that and been working with plans and issuers to reverse those types of exclusions, as well as medication-assisted treatment for opioid addiction. Again, a research-driven, proven treatment for opioid addiction, and we're seeing many plans that exclude that without explanation and actually provide the same medications if you had, for example, chronic pain or a medical surgical condition. So those are the types of concerns that we're definitely interested among many, many other non-quantitative treatment limitations. And as you can see on the slide here, another area of focus besides those types of exclusions that we're looking at is the limitations related that impact on network adequacy. And that's a priority, and has been a priority for us to look at those types of limitations. But that would include things like if you're a patient and you're trying to find mental health care, and so you open up your directory, you click online and to look on your online directory, trying to find a psychiatrist or trying to find a psychologist or a mental health provider, but you just can't find any in your area that are taking patients, or you can't, there are no appointments available, or maybe there are no psychiatrists in your network in your particular locality. Concerns like that that relate to those directly impact access to care. If you can't find a provider, then you're probably not going to get care, or you're going to have to go out of network and pay more. So there are a host of limitations that bring to bear on the question of who is in the network and the composition of the network, and is the network adequate. So I think those are some of the limitations that we're absolutely focused on, because they can be in many ways a threshold limitation to actually getting care. You may never have the chance to enter into a pre-authorization process if you can never find a provider or get an appointment. So those are some of our special focus treatment limitations that we are definitely giving more attention to. Next slide. And we can skip this one. This is just, it basically says that, my agency is successful, but we are a small agency. And something I did want to draw attention to is one of the last bullet points about inquiries. So I mentioned earlier about how each of our regional offices has a host of benefits advisors that man the phones during business hours to take live calls from folks with questions, folks who need help finding accessing their benefits, folks who are running into problems with pre-authorization, with what they think are limitations that might possibly be mental health parity concerns. Those are the types of queries that we get by folks calling this 1-866 line. It's 1-866-444-3272, and I believe that's 444-EBSA. And our benefits advisors have been tremendously successful. I think in the last in a completed fiscal year, they recovered over $444 million in benefits for folks who called in trying to get help. But not every concern can be resolved that way. So many of our best leads for enforcement cases, like actual investigations, come from queries that come through our benefits advisor line. So I would encourage you to distribute that phone number. And we also work very closely with state departments of insurance to share information or work with them on ongoing mental health parity investigations. So yeah, we get complaints and we get leads for our investigations from many places, the benefits advisors being one of the top places, but also from our state partners and our federal partners as well. Next slide. Yeah, so this is just a recap, just doubling down on if you want to call any of the you want to call the 1-866 number to reach a benefits advisor, or you can also submit questions online. And the Department of Labor's website has a place where you can subscribe to updates related to mental health parity. There's been a lot of activity lately with the final reg released last week. But yeah, that's sort of in a nutshell what we are working on. This is a really challenging space, but we are so hopeful because there's so much work to be done. And I feel like it's really telling that when the law was changed in 2021, just a few years ago, many plans and issuers really did not have a compliance analysis and still are challenged to identify their compliance analysis and a complete analysis at that. So our work is absolutely cut out for us all, and it's great to have partners in this space from all different angles.
So Tiffany, thank you very much. This is really important to everyone on the phone and all of the states and territories. This is important work. So Tiffany, if people have questions specifically about the presentation today, what's the best way? Could they email us and then we'll pass on the questions or concerns to you? Is that what would work best?
Absolutely, that would absolutely work. And if anyone has a question about a specific circumstance, like a particular person that is trying to get a benefit or is experiencing some type of barrier or difficulty with that, I would say the best line to call would be the 1-866 line, because then you can get an actual live person who can who's trained and yeah, routinely handles those types of queries. But if you have a question about the presentation, yeah, compile the questions and I'd be happy to field them.
Okay, thank you, Tiffany. Excellent presentation. We look forward to the next opportunity to connect with you.